and I spent the 2 years prior in Moshi, Tanzania, doing this group antenatal care study, among some other things. So, as we all probably know, you can't get anything done anywhere without a lot of collaborators, mentors, and funding. And I was very lucky to have Bernard and John Suya at KCMC, as well as here at Duke, within the OB/GYN department, Dr. Maria Small, John Bartlett and Nathan Thielman, and then the Duke Hubert Yergin Center, as well as the Fogarty International Clinical Research Fellowship. And we got all of the many research approvals that have to happen through Tanzania and through Duke and through KCMC, and those are listed there. So let's start with a little bit of background. So antenatal care is recognized as an important strategy to prevent indirect causes of maternal morbidity and mortality all around the world. And in Tanzania, we know that at least 98% of women attend one antenatal care visit, and 43% attend 4 or more antenatal care visits. And 30% of women are still delivering at home. So antenatal care, I don't know what to say no. Say no. Thank you. So antenatal care may represent a missed opportunity for improving maternal health outcomes, given that we want more women to deliver in the health center and we want more women to get some immunization and education throughout the antenatal care process. So what is group antenatal care? Group antenatal care was actually started in the United States, and they actually do group antenatal care here within the Duke Obstetrics and Gynecology Department, as well as UCSF, where I did my training. And it's a service for pregnant women to receive their antenatal care in a group. We use facilitative leadership such that the women, along with the facilitator, can sort of come up with their problems, discuss them together, and sort of find solutions together in a collaborative way. You should have a same provider at every visit, and a short sort of private time for each woman with their provider to do fundal height testing and listen to the baby's heart rate. And then it's a chance for the women to build a community and therefore actually have even more ties to be able to get sort of help and care within the pregnancy process. So we have some evidence that group antenatal care, or care for women in groups, does affect maternal outcomes and neonatal outcomes. There was a small a cluster randomized controlled trial in Nepal that showed decreased maternal and neonatal mortality that was published in the Lancet in 2004, when they looked at groups within Nepal or areas within Nepal that had group antenatal care, had group care during pregnancy, and those that did not have group care during pregnancy. In India, they found decreased neonatal mortality and depression, and in the United States, the sort of formalized group antenatal care model showed decreased preterm delivery rate, which we often use as a proxy for neonatal deaths, increased prenatal knowledge, and delivery preparedness. And no studies have yet been done in sub-Saharan Africa, though there are some whisperings of areas that are doing antenatal care in a group in various countries in Africa. So why should we change to group antenatal care actually in Moshi? We thought that they would facilitate the development and progress in the healthcare system, a sort of a systematized way of increasing access to immunizations, women getting more education and knowledge. It may save time for health personnel in the setting of healthcare personnel shortages, being able to see multiple women at one time. And women learn well from each other, and they have guidance in their learning, so maybe some misconceptions would be dispelled. And it might be culturally appropriate and acceptable in Tanzania. So we had 3 phases of our study. The first phase was the formative, and then we did some intervention development, and then we did a randomized control feasibility pilot from June to May of this year. And we actually performed this study at Majengo Health Center, which is a local health center in Tanzania, in Moshi. So for the formative phase, we did qualitative interviews, of which I got a lot of help from Dr. Melissa Watt. Some semi-structured interview guides in which we asked women, specific questions about their current antenatal care and group health, and what they would think of group care. And we did a convenient sampling in which pregnant and postpartum women and healthcare providers were asked to answer our questions as they came in for their antenatal care visit, and obviously as they were working for the healthcare providers. And we did these in both in-depth interviews, which were like one-on-one interviews, and focus group discussions. So in total, we had 31 participants. We did 20 in-depth interviews. 9 of the women were pregnant, 2 of them were postpartum, and we interviewed 9 clinicians, which included doctors and nurses and midwives. We did 2 focus group discussions. One had 5 pregnant women and one had 6 pregnant women. And as you can see here, just the demographics of the pregnant women, of the 22, their median age was about 25 years old. Most of the women had completed primary school. Most of the women were Christian, and most of the women had had no prior deliveries. So in terms of our formative research results, these were the categories that we came up with after reading through the in-depth interviews that we did, and sort of a lot of the categories were prearranged within the questionnaires, but then some other things came out as well. So about societal beliefs about pregnancy and delivery, the benefits of antenatal care, what women are actually desiring out of antenatal care, some of the obstacles to receiving antenatal care, and then after description of the group, what did they think would be advantages and obstacles of group antenatal care, as well as structural things that they thought would be important. So this is one representative quote about some societal beliefs about pregnancy and delivery. One first-time pregnant woman said, "I think those who consider pregnancy a happy experience are those who have planned as I did. I planned to have a child this year, so when I got pregnant, I was happy up to now." One about the antenatal care benefits is that you might have a health problem and you don't know, and you might be sick and you don't know, and so the benefit of going to antenatal care is to find out if any of these problems are existing. And then you'll be able to be told what you're supposed to do. This was told to us by a third-time pregnant woman. In terms of desires for antenatal care, most women desire to know the progress of their child and of the pregnancy, and they think that if you know your problems, it would be easy to avoid death during delivery. Sometimes the connections between what they said and how they would be able to avoid those things weren't clear, but this is what one first-time pregnant woman said. And then in terms of obstacles, the distance from the healthcare center was an obstacle, and in terms of how many meters you have to go, she could be tired and feel that it's very far, and that's why they don't attend antenatal care. And then in terms of group antenatal care advantages, we were able to describe what the structure of the group antenatal care was to each woman and to each focus group. And they then told us what did they think would be the advantages of getting their care in a group. And one woman said, "Therefore, being in groups, you can find that expectant mothers educate each other. Therefore, you can find that the one who doesn't know knows. Therefore, I think expectant mothers will be so happy because they will be educated." And this is a third-time pregnant woman who is 27 years old. It's interesting to think about some of these quotes even now, because it went from an English question to a translation into Swahili, to a Swahili answer, to a translation back into English, and then we read them and we made them a little bit more palatable for an English audience. So sometimes the grammars, when I read them out loud, I remember some of those challenges in translation and back translation. In terms of group antenatal care obstacles, one said it might be a problem in the group to keep confidentiality, and this came out a lot in terms of women being worried that other women would tell some of their personal issues that they might bring up during a group visit. And how can we be certain that the records are not discussed openly in the street, and perhaps so-and-so has AIDS and so on, meaning that they're going to spread the word that there's this one woman in the group who has HIV, and then other people within the community would know. And then some of the lessons for group antenatal care structure and lessons for implementation. We asked them basically, should we divide women by age? Should we divide women by parity, meaning how many times they've been pregnant? Should we divide women by different disease status? Should we divide women according to how far along in their pregnancy? And really across the board, there was no universal answer in terms of women should definitely be divided by age, or women should be divided by gestational age, how far along they are in their pregnancy. And this one woman said the age should be considered because a 14-year-old in the same group as an older woman wouldn't be as open to share what she has in terms of issues. But then other women said, but but an older woman could really teach a 14-year-old, what it is that they can expect during pregnancy. So we got a lot of varied answers about what about the structure and the implementation for the group. And then we also asked them specifically about HIV positivity, because we thought that that would be a major issue given that HIV is prevalent in sub-Saharan Africa, though in Moshi itself it's not as prevalent as it is in some other areas. And they think that people were split in terms of this as well. Some women thought you should divide them together because they wouldn't want to let other women's secret out, and other people thought it would actually be a marker, like a stigma, that these women are in the HIV positive group. So we didn't get a firm answer as to which way that should be, but this midwife did not think that they should be divided. So using all of that data, which sort of gave us an idea about what the women were thinking about and what the providers were thinking about in terms of how a group could be structured, how a group could be advantageous, and what could be the obstacles to the group, we developed the intervention. Now, what we already had to guide us was the United Republic of Tanzania, the Ministry of Health, already has guidelines about what should be in antenatal care. They recommend 4 antenatal care visits, and they have a list of what should happen at each antenatal care visit. It was from that list that we got the idea that things are being missed, and these are the things that could be assessed and shared in a group. And then we had the Centering Healthcare Institute, which is here in the U.S., and they already have like a large manual. They do workshops and sessions teaching people how to do the centering model of group antenatal care. And actually myself and my research assistant attended the Centering Healthcare workshop in order to learn some of their tenets and get a better idea of how they structure their groups. But 10 groups to 4 groups is what we decided we had to limit ourselves to, given what the Ministry of Health said. Also, through some connections through UCSF, I found out that they're doing group antenatal care in Nigeria, largely following the centering model. So this is the Severe Mothers Group, their facilitator's handbook. We were able to read through that and gather some of our sort of activities and ideas of what they focused on from there. And then really just going back to the healthcare workers, we did a session where we debriefed and we showed them a lot of these same ideas that the women had and the healthcare workers had, and asked them, sort of, what did you think? And as we had samples of the module that we were going to pilot, we asked them to read through it and give us some comments about things that were appropriate and things of that nature. So, as I said, we attended the centering workshop. We also pilot tested and translated all of our surveys and our each individual group among the women at KCMC who were there waiting to deliver. Women often come in pretty early in pregnancy, and so we sort of piloted the activities from the handbook with these women and got their feedback about how long it was and how appropriate it was, and got a sense of how women would talk when they were sort of freely in this space to do these activities. And we ended up holding 5 pilot groups for actually doing our randomized control feasibility trial. So with our pilot, I'll talk about that next. So we decided that our goal group size was about 12, based on the centering pregnancy groups that happen here in the U.S. And we expected about 30% of women wouldn't come to their full number of groups, given the number of women that attend one session versus the number of women that attend 4 antenatal care visits. And so we wanted to have 16 women in each group. So our total goal recruitment was about 32, but we were constrained in that, we start women at the beginning of pregnancy or as early in pregnancy as they present, and most women present at about 20 weeks in this area. And so in order to both get women as early as possible, make sure that they don't lose any intervening antenatal care visits, we really only had about a 2 or 3 week time in order to recruit our women. And so we included women who were pregnant after the first visit, we had some women who weren't sure that they were pregnant, and they're not universally doing ultrasounds and things of that nature. So some of the women didn't look pregnant, and they couldn't be included if they didn't have a positive pregnancy test on top of it. They had to be willing to receive their antenatal care in a group, and it was an interesting sort of conversation saying, you're going to be part of this study, and some of you will go to your regular antenatal care visits, and some of you will come to the group visits, but I can't tell you before you start which one of you will be. So again, had some really excellent assistance in explaining that in Swahili to the women we recruited. They had to be willing to attend antenatal care at Majengo Health Center, because we knew that we wanted women to be staying in the area, and a lot of women do go back to sort of their home villages or their husband's home villages for the rest of their pregnancies, and so they had to be basically from the area or planning to stay in the area. They had to be at least 18 years old, which is more of a Duke rule than Tanzania rule, and then less than 24 weeks pregnant, so that they could actually get in for antenatal care visits before they delivered. So we had a few constraints. And then we also wanted to have basically low-risk women. And so if they had high blood pressure, either because they knew it, which very few women did, or if they, at their first visit, their blood pressure was elevated, then they were excluded. Diabetes, if they had multiple gestation, which was basically a measurement if they thought they were so many weeks, but they were measuring farther along than that, then we weren't sure if there was one or two versus if the dates were off, so we had to exclude those women. And if they thought they weren't going to be able to return, we excluded them. So we recruited for just a few days, from the 11th to the 27th of January. We screened 43 women, 26 were enrolled and randomized, and then in terms of baseline data, we got their demographics, pregnancy history, their blood count level. We did a pregnancy-related knowledge questionnaire, and then we also made a copy of their antenatal card. And we ended up, by the grace of God, really, in my opinion, we had 13 in the intervention and 13 in the control, because we just did a basic randomization from a computer-generated numbering system. And we had 4 intervention visits every 4 weeks from February to May of 2012. And then in the follow-up data, we got all of the same information we got from the baseline data. And then we also did a client satisfaction survey, if you would recommend this to another person, and if they enjoyed the services, and then a birth preparedness questionnaire, meaning, where are you planning to go for delivery, how are you planning to get there, how are you planning to save money, or how much money are you planning to save for delivery services. So just some initial data from our participants. So just like in the qualitative portion of the study, the average age of the women was about 25, and most women were in their first pregnancy. There's really no difference between the group or the control. And most women were about 4 months pregnant at time of enrollment, which is also what we would expect given when women present to care. And most of the women were married. Most of the women had primary education. Most of the women were a Pari tribe overall, but in the group that actually got the intervention, there was a lot of women who were non-Chaga. That was a little bit surprising, because for those of you who've been to Moshi, we think that Chaga, well, we know that Chaga is the predominant tribe, so we expect that most of the women are Chaga, but I think that might actually be more prevalent in KCMC, and at Majengo there's actually a lot more different tribes within that area. Excuse me. We can see here a lot of the women were sales and service, so business women is what that came out to. And then what we found was really different between the two groups, which I was surprised at, was that there was really a big difference in the monthly stated income for the women in the group compared to the women in the control group. And part of what accounted for the women in the control group were, we had 2 women who were students, and so they stated 0 income. And then we had like 2 women in the group who had really, really high incomes compared to everybody else. So that really skewed some of the data, and might be better to use the median the next time we look at it. But there definitely was a difference in monthly income between the group and the controls. So what were the components of the group that we actually piloted at Majengo? The day before the group, we called each group member, and we also called the control women as well. But we called each group member to remind them about their visit and to sort of calculate the gestational age of the participants so we could save time at the next visit. And then we also called the alternative group members just to remind them to go to antenatal care visit whenever the antenatal care visit was scheduled. On the morning of the group, there's prophylactic medication that women are getting at every visit or every few visits in terms of prevention of worms, prevention of anemia. So we gathered that from the pharmacy at Majengo. And we wanted to be sort of at risk for the same outages that Majengo had, and that's why we opted not to buy those sort of separately for the study participants. We set up the room. We had bought an electronic blood pressure cuff as well as electronic scale so women could do their own measurements, and then we used Doppler to listen to the fetal heart rate, which is not what they're doing at most of the visits at Majengo. And then we covered a table with linen to measure the fetal heart rate, and we arranged the sort of room to facilitate the group meeting. And then after the group was complete, any referrals that needed to be made for women who needed ultrasound or further workup for blood pressures that we found, we wrote those letters and sent them to the various referral centers, and then we evaluated how the group went in our opinions, and then cleaned up the room. So you can see that it actually took quite a bit of time, even beyond the group, for the setup and the breakdown. So we started at 9. Women did their self-measurements. The nurse measured the fundal height. We gave them prophylaxis, and then we had the discussion. And then we also had this review of group norms at every visit. And the reason for that was, I mean, it's just good to do in general when you have these group settings, but also because of what we heard about confidentiality, we wanted to make sure the women were remembering that, you know, what's happening in the group stays in the group, and we're not encouraging you at all to share, you know, what you learn about people, but just what you learn in general about the pregnancy process. And then IBP is individual birth preparedness, and danger signs were the other things that we did at all the visits. So if we looked at the visits, I broke them down into the number of visits, like which one it was, and then the topics that we learned. And I think the thing that really stands out to me and stands out as a potential issue is that the time really was long. So we wanted the groups to be about an hour and a half. We thought that that made it time effective for the providers. If it was 90 minutes for 10 women, that's about how many women they're already sort of like shuffling through the system at this point. And to be longer than that may not be as advantageous to the providers. That's not to say it wasn't advantageous to the women, but as advantageous to the providers. So the first group was 140 minutes. The next group was 125 minutes. The next one was 160 minutes. And the last one was 150 minutes. And we had to stop them at the last group because we're like, this is the last group. And there were so many questions that sort of came up near the end that weren't directly related to like the pregnancy, but just sort of peri-conceptual care. And you can see we sort of had a different number of women at each group. And this is just a flow of how, from the beginning to the end, how many women we were able to keep within the study. So as I said before, we screened 43 women. 26 were enrolled and randomized, and then 13 to group care, 13 to routine care. And then the numbers under the group care is the number of women that actually came and attended the group, and they sort of slowly fell off over time, but not to a significant degree. And the one under routine care, this doesn't mean that they didn't get antenatal care. This just means that when we called the women after the groups to say, how was your antenatal care visit? What did you receive during your antenatal care visit? These were the women that we could actually reach. So adding up the total number of potential contacts that we could have with the women over the whole span of 4 visits, we had about a 34.6% loss to follow-up rate, which is within what one might expect, though I think we could have made some more efforts to sort of actually find the women with addresses and things like that, but I'll go into that. But approximately a 35% loss to follow-up rate over the course of this small study. So in conclusion, we know that current antenatal care is missing some educational components, and group antenatal care expands on education in terms of women advising each other. Group antenatal care is feasible as reflected by the attendance that we had in most of the groups over time. They're longer than 2 hours, which is not what we expected and not sort of how we planned for it to go. And further analysis of the group group compared to individual antenatal care is needed in terms of seeing if there's any of these difference in the pregnancy-related knowledge on some of the specific questions and receipt of some of the immunizations over time. So I will do that. I will do that. So we have all that data as well. It hasn't been analyzed yet. So some of the weaknesses of the study that we recognize, and our small numbers, just one location, one group, so maybe this is really just like a monolithic population, and other areas in Tanzania might have better or worse acceptance or attendance at these various group visits. We didn't follow women to delivery. I mean, ultimately what we want to know is outcomes, like are women delivering in the hospital, are women having fewer preterm deliveries, are women having fewer sort of hemorrhages because they're less anemic, those sort of things we don't know. And I think with a larger study, we would be able to get a better idea of those. The short study period, obviously. We weren't able to systematically evaluate the acceptability and the feasibility in the health system for the providers because myself, along with our research nurse, did all of the groups. And so who knows if this length of time of group or this sort of format of having this, if these women would really go over well with the providers. But the ones that we did talk to about the group, and we did make a video of our last group and showed it to them, they were sort of interested in that process. Again, in terms of the regional differences between Moshi and other areas, that's definitely a weakness to the generalizability. And the difference between the control group and the intervention group in terms of income, we're not really sure why that happened, one, and how does that affect the fact that the women came to more visits in the control group, in the group versus the women we could actually contact in the control group. So we actually have a manuscript in process. Actually, we submitted our manuscript about the group antenatal care model to one journal, and their response was that it seemed like it was more of a, what's the word? What did they say? Blanking on the word now. They thought it was more of like a, like not a full qualitative study, more just like a piece of something that should be bigger. And so they wanted sort of more information in terms of, that study. So we're working on sort of maneuvering it to another journal. And then we also did create a manual that's in both English and Swahili for group care according to 4 visits in the Tanzania Ministry of Health guidelines that we're working to make it a little bit more tight, such that other people could actually use it and pilot these groups as well. We have a video that we need to splice to make it sort of a short, good teaching tool for how this group antenatal care works within this population, and then to write up the rest of the quantitative data and dissemination of the results to all the other people that we've been working with over the course of time. So that concludes the majority of the talk. I just wanted to say thanks to all of these people who helped with the study, and there's many, many more over the course of the time that I was at the fellowship between Duke and Tanzania. So just thank you to everybody that helped to make this possible. And any references? So this is just a picture of our group fuzzied over. Those of you who've been to Moshi might recognize Dora, who was our research nurse and is now actually doing a master's in international health in Bergen, Norway. So we're really excited about that. She's been really excited about the opportunity to sort of pursue her research career as well. And this was our group. So asante, this is thank you in Swahili, and we'll continue questions.
This was great. It was nice to sort of see everything together because I talked to you about pieces of it. I was just struck by hearing kind of the qualitative results, how like people's perceptions of the value of ANC is very much about kind of this top-down, like getting, getting advice from the expert. And my sense is like that's how clinical care is. It's like it's like the white coat effect to kind of an extreme.
Yeah.
That you don't question the doctor and you don't necessarily engage. You just go there to get the information and ask, and he or she tells you what to do. So the group ANC model is much more, of course, the ideal is that it's much more horizontal, that there's more peer learning, that there are opportunities for engagement. And so I was just wondering, like, how that worked and how sort of culturally salient that idea was, and to what extent, women were engaging with the providers.
No, that's a really excellent question, and I found it very interesting as a clinician working over there as well, that nobody comes to you with like, well, I Googled such and such, and shouldn't I do well? So yes, it is very much that the women are interested in, like, is my baby okay? Is this pregnancy okay? Tell me what to do. But as the groups developed, and they got to know each other, they were definitely more interested in talking with each other. Though they always sort of needed like a provider check-in. Like someone would say, I know that, I wish I could remember something specific, but I know that XYZ happened in pregnancy, and they would sort of look at Dora and she's like, yeah, keep talking. And that was part of the reason that I actually brought Dora here to do the centering workshop, and myself as well, is because the facilitative aspect of group antenatal care is so different from how you're sort of taught in a lot of ways to even provide medical care, and you sort of have to like trust the process that some of the things will come up and you can can add what's right and wrong, but a lot of times the answers are known among the women and you want them to be able to come up with them. So it really, the first time it was a lot of Dora talking and the women talking to Dora, so it was like Dora at the head and then all the group to her, but then by the second and the third visit you could really see that they were talking to each other and you could see much more of the interconnectedness. So it takes a really special facilitator, I think, but I don't think that the facilitation skills cannot be learned. They just have to be sort of accepted by the facilitator who's actually doing it. That's a good advice.
And it makes me think too about, like, if you to do a next step, and if you do a larger trial of this, what are the outcomes that you're most interested in? Because I would imagine there might be some sort of like some outcomes that are less clinical that might be more about like self-efficacy to engage with providers, or a sense of like constructs that are more around kind of confidence and empowerment.
Yeah, that would definitely be some of the tools that would be important in sort of like follow-up studies to see how the women are sort of changing in their sort of control.
What was going on culturally or educationally that lengthened the sessions out beyond your expectations?
That's exactly what I was
So I think in the first sessions, it was that women were hesitant to speak. And so we did small activities that then are supposed to promote like a conversation, and the dialogue's not really coming. So you're sort of trying to pull these things out. And then by like the third and the fourth session, we couldn't get the women to stop speaking. And they had, I think as they became more comfortable with each other, they had more to say and they had more questions. And whereas we would have like one woman like demonstrate breastfeeding with like a doll, for example, in one of the groups, and then somebody else would be like, well, I want to try, and I want to try. And I want to try. So, you have one like demonstration by a woman that's correct, and then everybody else wants to see if they do it sort of in a way that's acceptable to the group. And so that transition from the beginning of not being able to get people to really speak and really having to ask multiple questions to pull these things out, to the end where you couldn't get them to stop talking. So, and it was really interesting, the last group especially, we talked a little bit about sex during pregnancy, which I didn't think would go over well. And we also had it video recorded. And it was a male video recorder, so I'm like, this whole thing is going to be terrible. And they really did talk just freely and easily and a long time about it. And just some interesting questions that I didn't think would come up. But some interesting questions that came up during the group, and they were fully free, and we had to stop them. And I had the videographer tell me afterward that he wanted to turn off the camera and like also talk. That would have really not been good, but yeah. So that's what I think is happening throughout the course.
So, who are the clinicians or the providers that this type of group would typically see? because it sounds like Dora, or the research assistant, was the main facilitator together with yourself.
Mm-hmm.
In the control, are they mainly going to physicians or midwives, or who would this replace?
The midwives would be the facilitators. And, you know, we have a National Association of Midwifery here in the United States, but a midwife there is a nurse who is interested in women's health and therefore has sort of moved into doing mostly antenatal care and deliveries. And so it's basically replacing a nurse who is interested in women's health.
Did you have to do any kind of facilitation? Were they in any way threatened by the notion that this would somehow be viewed as a substitute, or would they be more relieved that, you know, there are 13 other patients that, you know, I would have to see added to my schedule that maybe would be difficult?
Well, we framed it such that the 13 patients that you would see one at a time for 15 minutes each, you'll see them all at the same time for about an hour and a half. And in that framing, nobody felt threatened. They just thought, okay, we can, you know, then see more patients at the same time. And some of the things that didn't come out from these actual quotes was, one, we did have to explain that this isn't like you can see them all sort of at the same time and let them do everything and you can do something else. So that was something that we had to dispel, that this is not something where you can't pay attention to them, you know, they just learn on their own, you're doing something else, and you sort of check in. No, this is actually you engaged with the group. So that was an interesting thing, but nobody was threatened by their job, but they were more threatened by, like, well, this is not what the Ministry of Health says, that this is what we should do. You know, you really have to educate people, and it would have to be accepted by the government for us to do it, because we're not trained in this way.
Who facilitates here? Is it nurses?
Midwives, doctors, yeah. So, you know, midwives are nurses as well. So, yes, in a way. Does that make sense? Yeah, and then the residents also did it. The residents are doing it here at Duke, and where I trained 2 residents were facilitating the groups.
This might be a naive question. I missed the first important half of the presentation. So 2 questions. One is, did you, when talking to especially the clinicians in the group, did you get a sense that there was any fear that if this is expanded out, there would be any substitution away from clinical responsibilities? That is, they would start spending time on the group activity, which is great, but does it come at the expense of something else? And the second is, I wanted to go back to Melissa's question, is if you were to do this again or on a larger scale, I hope you will, what sorts of outcomes would you sort of really focus on?
So in terms of your first question, if clinicians were worried that it would take away from their clinical duties, doctors themselves, they weren't worried, the ones that we talked to, but probably because it's not mostly doctors doing antenatal care. It is the nurses and the midwives doing antenatal care. And the midwives, if they find an issue in the pregnant woman during their evaluation of the patient, they refer them to the doctors, and the doctor takes care of like the diabetes or multiple gestations. So the doctors were sort of all for it. We did have a few who said, well, we want to sit in on a group and to see what's happening so that we know what the women are learning that then we might have to, we might get questions about. But the doctors weren't fearful in that direction. In terms of your second question, in terms of outcomes, I think that self-efficacy is one thing to definitely look at among the women. I think provider satisfaction would also have to be another thing. And then the hard outcomes of, I think, neonatal mortality and morbidity and maternal mortality and morbidity. But of course, as we know, with maternal morbidity and neonatal morbidity, well, mostly mortality, there are such rare outcomes that you would have to focus on some of the more proximal ones like PPH or preeclampsia. I think anemia is a good one to focus on because women who are anemic are more likely to have postpartum hemorrhage. And then preterm deliveries, because those happen a little bit more often and can be linked a little bit more with like infections and hygiene and things that are a bit more behavioral.
I wonder how they adopted the aspects of self-care. They were receptive to taking their own weight, for instance.
Oh, they were really receptive to it. They sort of enjoyed it. They did. Some women got it a little faster than other women, but they enjoyed the ability to be like, okay, this is my blood pressure, and this is my weight, and this is where I write it down on my antenatal card. I mean, some of them had never looked at their antenatal card. They just give it to the provider, and then they put it back in their purse, and it's like the gateway into the health system. So So they actually were really receptive to that.
Yeah, you may have mentioned it while I was out of the room. How did you deal with HIV and confidentiality in your study? And then beyond your study, if this were to be implemented on a much larger scale, how would you deal with it? Would you cohort HIV-infected individuals, or would you try to have group discussions? Because it strikes me that antenatal care would actually be a good bit different.
So we didn't have any HIV positive women in the study, so we
Yeah.
didn't have to deal with it. But we did think about how we would deal with it, and we were just going to let them be in the group or not be in the group. The thing about HIV care at this point, it's still not all taken care of within antenatal care, so they go to their antenatal care visits and they still go to like HIV care visits. And it would be nice to, eventually streamline that, and they have done that in a lot of countries, but they're not doing that in Brazil. Like if they're HIV positive, they still get a separate visit with a health care worker because of their HIV positivity, who prescribes certain conditions and sort of monitors that. So we had planned that we would let them be in the group and sort of talk about HIV during the group. If they felt compelled to disclose, they can disclose. We would not disclose, and we would just sort of in private encourage them to keep going to their HIV care provider. Well, thank you all for your attention and your great questions. And I hope you enjoyed the talk, and hopefully we're going to get this paper out to somebody else. But, thank you.